Next speaker is Dr. Sanjeev Jain, our IEA president, on THN proximally migrated hips. Which one to choose, high hip center or subtrochanteric osteotomy?
So good morning. So I'm going to speak on total hip arthroplasty in either proximally migrated hip, whether you need to do a high hip center or do a subtrochanteric osteotomy. So proximally migrated hip means that where the femoral head is migrated significantly upward in the acetabulum and causing pain and dysfunction. Definitely there's going to be an abnormal morphology, growth and orientation. Of course, the worst thing which can be a soft tissue alteration, and that is sometimes difficult to correct, and it's a very challenging situation because complications rates are very high. And whatever is described in the literature, also the old techniques remain the same, but the implants and other possibilities were not that great that particular time, maybe around 20 years back. Now you have a better implants, better augments, another thing to challenge that situation, and you can do it again very safely. Mostly problem is that these common problem are also in a younger patient, so you need to think about a long-term data or long-term longevity of that implant, and of course you need to be very thorough with some historic classification, and usually these are the dysplastic hip, but it's not necessary that high hip center should be dysplastic hip. There are a couple of papers are published by the Indian authors as well, and you need to be very careful about classifying this into CRO 1, 2, 3 and 4, and you need to also understand what is the percentage of rate of dislocation is there preoperatively, whether it's CRO 1, CRO 2, CRO 3, CRO 4. So CRO 4 is completely 100% dislocated high riding hip, and radiologically they look like this, and you need to also do some other investigation in form of CT scan sometime to find out the real bone stock and the socket configuration. Now, the proximally migrated hip does not necessarily mean this should be only hip dysplasia. You can have in our country many other problems which can lead to the proximal migration, and this could be an old septic arthritis equally, acetabular defect, childhood arthritis, revision total hip arthroplasty. When you see in aseptic loosening, it's proximally and sometimes more medially migrated as well. Long-standing excision arthroplasty where the hip goes very high, very advanced rheumatoid arthritis, and of course the neglected trauma. So there's a beautiful, excellent paper is written by one of the colleague who was here, Anil Oman. He's written a very good paper on this particular topic, and one must read that paper to understand that problem. Now, problem with the high hip center is that you don't have a good bone stock and you cannot put this hemispherical socket. So you need to have at least a minimum contact to the host bone, acetabular component and host bone, and which should be at least 70%. This concept was popularized by William Harris, and he felt there's no disadvantage, but there are some paper came later on and which says there was a high rate of loosening with this high hip center, but probably the pathologies were different. Techniques in the challenging is two things. One is the bone stock. You have to be careful, which should be sufficient. High hip center should not be lateralized. That's very important. Otherwise, you have very, again, dislocation chances and loosening. These are the small patients, so component size could be a problem. And you need to also see the limb length should not be a major issue. Otherwise, patient will not like it. There are different criteria for high hip center have been described, how many millimeters should be above the teardrop line. Different authors have publish it, but it should be more than 22, and they have described, and the Harris has described up to 28 millimeter above the line. Now, you need to definitely resect the femoral head, which can ream the acetabulum medially and proximally, not upwards, and of course you need to have at least, as I explained, the minimum contact of 70% to the host bone if you are using a high hip center. Subtrochanteric osteotomies are described when you have to bring down type 3 or type 4 especially to the original socket, then subtrochanteric osteotomy can be done. Now there are challenges with this reconstruction because you have acetabular dysplasia, femoral underdevelopment because canals are very low. You have a lot of anatomical problem there, high riding greater trochanter, of course limb length discrepancy and very tight and short abductors, and of course the sciatic nerve is also very tight. So this is one of the case example of CRO 4 high riding trochanter. We need to, if we have to plan the subtrochanteric osteotomy, there are steps we need to know about how does it go about it, and you do a pre-op CT scan, just see the acetabulum, where is the native acetabulum, and you can see the any kind of other reconstructions required. You plan to restore the socket length of the femur you have to, and of course sometime you have to reattach the greater trochanter. So first you dislocate the hip and definitely use that head to reconstruct mostly the posterior superior wall, which I'll be showing it here. That you have to reconstruct the posterior superior wall, put one screws, and then you put a trial. So your socket is reconstructed in the original place, and there's a calculation describe how much you have to cut the subtrochanter. If you see here, I have after dislocation I have cut it, but I have not completely cut. I have just cut the bone and on a subtrochanteric area. But you need to shorten the femur later on because this makes your acetabular. If you do the osteotomy here, this makes your procedure very easy, and you can really bring the femur forward and you can reconstruct the socket very well. So reconstruct the socket, and finally this is the way you put a socket. Later on you do subtrochanteric osteotomy. These stems are usually not available now, the acerome stem, but this is one of the good stems. We have also other good stems available. These is very old x-rays around 15-20 years back which we have done it, and I've lost her follow-up at 12 years. These osteotomies usually unite, as sometimes you have to wire it, and of course these grafts has to be protected with the weight bearing, otherwise they will collapse, and this was the 12 years follow-up. So I was talking about this paper described by Anil Oman, and one must read it about it, where you can do in a different condition which we are there in our country with different kind of patient. One of the pathology is described in enclosing. You can again do a subtrochanteric osteotomy here to bring your head down to center of rotation down, and naturally you have to be very careful about the sciatic nerve palsy. So there are different papers available in the literature. They have a different concepts, but there are systemic reviews, and it is described that they have got an excellent result with newer implants. And you go through all those things in the literature. I'm not going to go through because of the lack of time, but yes, you can perform an excellent hip in a high hip center, provided you respect the anatomy, provided you have a correct kind of implant, and of course you have a patience, and of course take care of the sciatic nerve. That's very important because very sensitive to a traction injury, and that can lead to a problem, and of course sometime litigation as well. Being a president of Indian Orthoplasty, I would request all of you to join Indian Orthoplasty Association, which is our Indian association, and of course to contribute to also we have started the Indian Journal of Orthoplasty. Mrinal Sharma from Delhi is the editor, chief editor. So you can go to the website of Indian Orthoplasty, join. Of course, the next our meeting is again in the same place in Ramada, which is October 30th, 31st and 1st November. So we expect a lot of support from this region, and people should join that conference. Thank you so much.
Thank you, Dr. Sanjeev. It was a very nice talk.